guys, I just wanted to get started on our first chapter. It's chapter 1, what your role is in the changing maternal health and healthcare environment. I wish we could go over a lot of this in class, but there is just not enough time to get everything done in our classroom. So we're going to have to listen to these recordings and do the best we can. There may be still a couple of test questions, but I will really stress what's going to be important and what you really need to know. So just looking at, in general, healthcare, and of course my slideshow's not going to work. Okay, but there's a lot of things that are going on different in healthcare today that we didn't really have several or many years ago. These are just a few of the things that are going on. I'm not going to spend a whole lot of time on these. Some of them I may even skip through. So to kind of save you some time watching some of these videos. But today in the world that we live in, a lot of our pregnant moms have a lot of other complications that we're having to deal with. There's a lot of different challenges that we're dealing with now. A lot of technology has been brought into maternal fetal health, so we're thinking about those. There's a lot of ethical decisions that we're going to be thinking about. Demographics has changed. Society as a whole has changed. So there's a lot of different things that are changing in our healthcare and the way that we take care of our pediatric and our obstetrical patients. So a couple of things that are changing. One is the family structure. You know, we have a lot of different family structures that we didn't have 100 years ago. We have a lot of single families. We might have a dad raising children, moms raising children, grandparents raising children. So there's a lot of family structural changes that we're seeing. You know, and then who's responsible for paying, which we're going to get into that a little bit more. We do have a reduction in the communicable infectious diseases, one, because we have new technology, and we also have vaccinations. So those have pretty well eradicated a lot of our childhood illnesses that we normally would have come in contact with had we not had the vaccinations. So we're looking at a lot of different kinds of things like that we're going to be discussing. So a couple different concepts that I kind of want to just bring to light. Most people in today's world, especially where we live, are delivering babies in the hospital. But we're going to talk about other places that babies can be born. There's birthing centers. We don't have them here, but we do have them in more of the cities and things. But years and years ago, most of our babies were born at home. They had a midwife, or they had grandma who had delivered several children, and we that was just the way that it was. There was a high maternal and fetal mortality rate just because of a lot of that. There was a high mortality rate because of infection, illness, hemorrhage, all of the things that we weren't able to treat at that time. But there's a lot of things that are going on now. When you look at obstetrics, you look at, you have an OB doctor, but many times there might be other specialties that'll be involved. A perinatologist. A perinatologist is someone that if mom has complications during pregnancy, she might see her OB, plus she's going to see a perinatologist, and all they deal with is the baby that's inside mom. And then there's neonatologists. Once the baby's born, then they take over the care of just the baby and not the mom. Mom goes back to the obstetrician or the perinatologist. And then pediatrics. You guys have already been through peds, so we're not really going to talk a lot about peds. But historically, like we talked, most births were done at home, and now they're being done in a hospital. Usually it's going to be done by a physician or a midwife. And now, a midwife isn't able to do a cesarean section. So your OBGYNs are going to be doing that. And we've got so many advancements, so many technologies that we used to not have years and years ago. Babies, it's a natural process for babies to be born, but once you get through this course, you're going to realize how many things can actually go wrong during pregnancy, during delivery, during postpartum section. So you'll be seeing a lot of that, and the advancements that we've made, throughout the years has been great. I mean, now we have internal fetal monitoring, we have external monitoring, we have genetic testing, we have a lot of things that we didn't have before. So our midwives do a very good job of delivering a lot of the babies, and many times they go successful and there's not any problems. But they provide a lot of support, a lot of encouragement. If it comes time and the baby can't be delivered, then sometimes they will have to call in the physician to come in and do the cesarean section. But, those are things that we didn't really have years ago. They just try to do the best they can with delivering those babies, and many times we had poor outcomes. So we've made tons of advancements over the years on that. But there's two major developments that really took place that really influenced the way that we deliver babies and the way that we that help increase or decrease the mortality rate of our moms and our babies. One is acceptance of the germ theory. Years ago, there was a person, his name was Agnes Salamowitz, that's probably wrong, but he was credited for kind of recognizing puerperal fever. So what that means is a lot of times moms after birth, because of the birthing process and a lot of the bacteria, the germs and things, the moms would get infections after delivery. Well, what he did was he set up two different places. A clean place where they were washing their hands and they were cleaning the instruments and they were doing things like that. And then he kept the other ward going just like they had been doing before. Many times these doctors might go in and take care of somebody that had an abscess, or they would drain something and they didn't have gloves. They would just wash they didn't even wash their hands. They would just go from one spot to the next spot. They didn't clean their instruments. And over time, Agnes kind of realized that, man, this group over here that was cleaning their hands and really disinfecting things and trying to make things better, these moms did a lot better, less mortality than these moms over here. So that was kind of recognized, and a lot of people kind of told him, oh, that's not true, but he's kind of recognized for developing that theory of that germ theory. The other thing was development of anesthesia. Years ago, we didn't have any type of anesthesia. There was nothing to assist moms during birth, and the birthing process, they don't call it labor for nothing. So it's very, very painful. And prior to a lot of anesthetics, moms just had to deal with it, and sometimes it was extreme excruciating pain. So what kind of started taking place probably about 50, 60, 65 years ago, we would put moms in what they call twilight sleep. And they would just kind of put them out a little bit, and they would deliver the baby and the moms would kind of be out, or they would give them like a pudendal block. Now we have advanced where we give epidurals, we do all kinds of spinals, we do lots of different types of things. But we give moms more control now over how they want their births to go. So used to, it was up to the physician. You would come in, you're gonna come in, you're gonna labor here, you're gonna deliver here, you're gonna go to postpartum here, baby's gonna go to nursery, and that's the way it was always done. Now, a lot of places you can go in, labor, delivery, postpartum, the baby room's in with mom, everything is in one room. And that, we let moms have a birthing plan now, so they get to decide if they want to, what kind of pain medication that they want, if they can change their mind, what kind of things that they can do. So they've got, moms also have more control over that delivery. So I'm not really going to talk about pediatrics care, but just one of the big things that I want you to remember is vaccinations was a huge key player in childhood morbidity and mortality, as far as like Haemophilus, smallpox, the flu vaccine, DPT, diphtheria, pertussis, whooping cough, measles, polio, all of those things. Without those vaccinations, those diseases would still be here, and some of those diseases were fatal. So they were very very life-changing when we started getting some of those vaccinations. So now we're kind of looking at family-centered care. What we've kind of looked at is everybody kind of looks at childbirth as a safe and natural process. Yes, it is a safe and natural process. Most of the time, probably 6 out of 10 times, everything goes smoothly. However, sometimes it doesn't always go smoothly, but the family-centered care is what we're recognizing is the birthing process should be a family centered care where, if the mom gets to decide who is in there with her, that's part of her birth plan. And, she may just want her husband. She may just want her significant other. She may want the whole family, grandma, grandpa, aunts, uncles, all the people. So that's what she gets to decide. And that's what we think about family-centered care. Used to, 50, 60 years ago, dads weren't really even in the delivery room. They weren't even allowed in the delivery room. The dads would sit out in the waiting room. Once everything was over, they would bring the baby out, show dad, and that was that. Times have changed. We feel like, including that family in the birthing process really helps to incorporate their culture, their family, just make it more of a bond between everybody. So we try to recognize that and make that as much as possible as we possibly can. So we're trying to work on that with a lot of the different types of things. Another thing that we have changed is centralized care. So centralized care just means that most of the time we can receive care where we live. However, sometimes centralized care goes, you may not be able to get it here. If you think about a child that has type 1 diabetes, we don't have a pediatric endocrinologist here. So they're going to have to go to St. Louis or a surrounding area where that specialty is available to them. We also have done tons of advances in research. Think about before we had infertility treatments, how many women and families were not able to have children. The diagnostic that we can determine now if a child has a congenital abnormality. We can do genetic testing prior to even, prior to even getting pregnant. The moms and dads will know if they have any genetic abnormalities that can be passed down to their children. Then they can choose to have only the good embryos implanted. So there's a lot of things that we're doing that are advances. They also can involve ethical issues at the same time, but there's just a lot of different things that are out there that we can do. So then again, we talked about the ethical issue there. The Human Genome Project, prior to probably about 20 years ago, we weren't able to map the genome. We didn't even really know. We knew we had chromosomes. We knew there was 23 in an egg and 23 in sperm, but we really didn't understand the genes or how they went into place. Now we can actually map the genes, and it actually tells you all of that stuff. So some people don't feel that is appropriate. Some people feel that is, taking away the natural process of it. So it is an ethical dilemma when you stop and kind of think about it. Surrogacy, treatments for very, very preterm infants. We're actually able to save infants now. 24 week is kind of a critical time period. A baby born between earlier than 24 weeks does not have a real good chance of survival. However, we say that today, but we don't know what 10 years is going to bring. We don't know what 5 years might bring, that we might be able to save some of these babies or put them, who knows what we can do with them. Demographic changes are changing. People are ever moving. People get jobs and then they move to different areas. So we got all kinds of demographic change, trends that are going on with people all over the place. Cultural differences. We know that, kind of in our country, we have lots of different cultures, and we need to be able to meet the expectations and things that other cultures need us to meet as nurses to be culturally competent and taking care of them. Poverty and cost containment are things that we have to look at because, women who are living in poverty probably don't have the ability to get to the doctor for their prenatal care. They don't have the knowledge that they need, that immunizations are important, prenatal care is important. We need to know about your health. We need to know what your mom's health was, your grandmother's health was, so we can help determine how well that baby's going to be successful, how well your pregnancy is going to go, how well things are going to go. Cost containment is very important because we know right now the cost of healthcare is kind of through the roof. The more equipment that we use that doesn't need to be used, or the duplication of tests or things like that, it's just going to cost us more money in the end, and it may, possibly make things more inefficient, and that might be the difference between you getting an extra nurse on your unit to help and them saying, no, we can't afford that nurse. So, think before you grab something. do they already have that in their room? Have they already had that test? Do they need to have that test again? Duplication of things like that help. Getting, social services involved and case managers can also help with some of that kind of stuff. And that's what we're going to kind of talk about now, is just how do we contain some of that cost. So it's expensive. I know my daughter had a baby in St. Louis, and her bill was $60,000 and the baby's bill was $70,000. So it's expensive. So case managers can kind of monitor, and they can coordinate all that care, make sure those moms are getting to the doctor, make sure they're getting their testing done like they need to, make sure we're not having those overlapping services and we're not having duplication of testing. Critical pathways is kind of like how we talk about the nursing care plan. Clinical pathways are kind of like that too. It's kind of a standard care plan that we use as a team, and it kind of guides where they need to go. Okay, so if you got a mom, her blood pressure is this, maybe this is where we need to go. But if you have a mom, her blood pressure is this, her platelet count is this, and this is going on, maybe that mom needs to be transferred to St. Louis. So there's certain pathways that we would do that would go to certain places. And that's kind of helpful to help us guide our practices and have better outcomes. So thinking about payment for health services. It's something, as I think young people, we don't really think a whole lot about, but as you get older and as you have children, you start really thinking about, how am I going to pay for all of this that is getting done? Many times, if you have employment, your employer will provide you with some form of health insurance. If you don't have that, or you can have your private insurance, which you can purchase on your own. You can also purchase it through the health exchange, through the Obamacare that took place in 2010, where we have like federally funded insurances on there, and you can purchase an insurance plan through there. But we also have federally funded sources that you can get. Medicaid is generally for people who are below the poverty level, and that provides them with insurance. One of the big things that we started was we were finding that many people and children were going without insurance. So we started doing the state child health insurance program. So what that means is any child, I'm pretty sure it's under 19, can get health insurance through the state. Now, depending on how much the parents make, they might have to pay a copay, but every child is entitled to the health care in their particular state. Every state's a little bit different, but that's what we have a federal mandate that started. We also have like WIC services, so that's for women and children. So like moms can get milk, they can get vitamins, they can get healthy foods, they can get 100% juices for babies, and that way we start those babies up with the best care that we can give them. We also have specialized services. If you have a baby that is born and has congenital anomalies, possibly they've got like club feet, something like that, then a lot of times the Shriners Hospital does a lot with like bone abnormalities, things like that, and burns. Easter Seals will do like disabilities, of babies born with disabilities. St. Jude's, we know that they take care of a lot of children with cancer. So there's different avenues that people can go to get services, to help get services paid for. So thinking about maternal and infant health status, so when you think about that, infant mortality rate, what do you think is the number one thing why babies would die? One is probably congenital malformation. So the baby just didn't form correctly. Possibly certain systems did not form. Chromosomal abnormalities. There are certain chromosomal abnormalities that is inconsistent with life. So you can have a trisomy. You can have a trisomy 21, which is Down syndrome. Trisomy 18, but usually trisomy 18, they usually die. So when that sperm and egg come together, and those 23 come together to get the 46, somebody has an extra chromosome there or doesn't have a chromosome, and it matches up, and then we get this malformation. And some of these disorders can be, they can give you like low birth weight. Sometimes if moms have other underlying health conditions, that can cause some problems too. So we got to think about all that. Does mom have diabetes? Does mom have hypertension? Is mom malnourished before she ever got started? Is mom a smoker? Does mom do illicit drugs? All of those things are going to play a role in your infant mortality and how well that baby's going to develop inside mom. Mom is in charge of developing that infant up until 40 weeks. Maternal mortality rates, so this is the mom's mortality rates. Usually moms, the biggest things that moms are going to die is hemorrhage afterwards. Sepsis, they get, an infection, or they get a hypertensive disorder like HELLP syndrome, or they get eclampsia and end up dying from something like that, a pulmonary amniotic embolism. So there's all kinds of things out there that can happen with moms, but those are the leading causes of why a mom would die during delivery or after. So how do we reduce that? How do we reduce that infant and maternal mortality rate? Well, before moms even conceive, they can go to the doctor and they can see what kind of health risks that they have. They can do the genetic testing. They can make sure that they're eating good foods. They can take extra folic acid and iron, build their iron storage up. Folic acid helps with neural tube defects or like your spina bifida and things. Avoid alcohol and illicit drugs. All those are things that you can do prior to the babies, prior to even conception. And then during pregnancy, it's very, very important that they get their prenatal care. They need to make sure they got all their vaccines and educate. We need to give them materials for them to read, but we also need to educate them verbally, have them, teach back. What did I tell them to do? And then the postpartum period, make sure all that baby gets all their vaccinations. There's kind of a trend going on right now that a lot of moms are refusing to get the vaccinations. So just educate them on the vaccinations, let them read about them, and tell them that, it's a good thing for the baby. Educate them on baby care. How do I take care of my baby at home? And breastfeeding, and how do I do breastfeeding, and then sleep education. And we'll talk a little bit more about sleep education here in just a little bit. So we're not going to talk a lot about this because pediatrics will take care of a lot of this. But one thing that we did help to improve child's health, and I think this is where it is kind of important, is we did start the newborn hearing screen. So every newborn before they leave know if they have a sensory neuro hearing deficit before they leave the hospital. And that way they get early intervention and we can maybe help those babies prior to, starting to develop language and things like that. The Back to Sleep campaign, making sure that we're keeping babies on their backs. Babies should not be in mom's bed. They should, not have any blankets, nothing in the bed with them, no stuffed animals, nothing that could do that. Breastfeeding in the workplace. It is legal not to allow women to breastfeed in their workplace, so they have to be given time and a place to be able to do that. And just immunization awareness, making sure that people are getting their immunizations. And we have something called Healthy People. I don't know if you've ever heard of Healthy People, but it's something that the government puts together, and we do it every 10 years on the even decade. So we just finished Healthy People 2020. Now we're moving to Healthy People 3030. And what we do is we set goals. As a country, we set goals to make advancements, to help people help certain things. And it's not just maternal health. This is everyone's health. But there is a section about maternity. And so we set goals. And then in 2030, we will look back and see if we made those goals. But you can get on and look up Healthy People 2030, and it will show you all those goals and improvements that we're trying to make. So thinking about the nursing process, we've talked about that a lot. So assessment, that's all your data, whether it's subjective, objective, whatever it is. And sometimes that data changes. Sometimes that data, you might have been in the room 10 minutes ago and you come in now and that data has changed. So if the data changes, we have to make changes to meet and accept that new data that we got. Then what we used to call it was nursing diagnosis. Now we're kind of moving to that nursing focus. And so what is the focus that we're looking at? What is the main focus of that patient today? And then we're going to give them a goal. And that goal usually has to be something realistic, and it has to be something that we can measure. And then we're going to implement it. So that's where we're going to put in, what are we going to do? How are we going to achieve that goal? How are we going to make that happen? And it might not just be nursing. It may be other interdisciplinary PT, OT. It might be having them see someone else. It might be a lot of different factors that need to come into the implementation. And then evaluation, how did it work? Did it work? Did it fail? Do we have to go back and relook at it again? The biggest people we need to make sure it's in this is all of our collaborative team. We need to make sure the patient's in there and the patient's family is involved, because sometimes when the patient doesn't have family, we got to get the family on board to help keep the patient on board. So all those are things that we're going to do. And to think about that, documentation is one of our biggest things. You guys have all been through P&E 103. Documentation is very critical. Documentation is a legal document. It has to be accurate. It has to be complete, because if anything ever goes to court, it will be pulled to do that. Remember, if you didn't document it, it didn't happen. And if it didn't get documented, they can cite you for those kinds of things. So just always keep your documentation in mind and just know that it needs to always get done. All right, end of chapter 1.